Hi, yeah, so I used to be a respiratory physio. I specialised in intensive care, so as much as possible I get involved in the ICU here and stuff like that. I'm weird, I love phlegm. So, we are going to look at what are the indications for respiratory physio. This is true for, I'm basically talking about dogs here, potentially cats, but they're a little bit smaller, so you've got to be a little bit more delicate with them. But the indications are still the same, so you're looking at anything that is causing decreased lung volumes, which would be either atelectasis or consolidation usually. Sputum retention, physio is brilliant for sputum retention, hence I love phlegm. Prevention in the recumbent patient, the more recumbent your patient is, the higher the likelihood of them getting pulmonary complications, and if you add a post-op, so an anaesthesia into that as well, then that increases that risk even further. And also then rehabilitation post-morbidity. So respiratory physio doesn't just stop when they've got over their pneumonia or their pulmonary complication. It continues when you've got the cardiovascularly deconditioned patient that you then need to get up on their feet and get them fit and healthy and working again. Everyone's got a cough, or at least dogs, cats and humans do. So it is an automatic thing, but it's a very clever little bit of a mechanism that we've got going on and quite life-saving. It is a Valsalva manoeuvre. It is a defence mechanism. The whole point of it is to remove secretions from the 4th generation bronchi upwards. If you think about how many generations of bronchi we have, dogs, cats, everyone, we have a darn sight more than just 4 generations. So every generation is where it bifurcates. So your carina and your 2 main bronchi, then that's your 1st generation. 2nd generation is the next bifurcation. 3rd generation is the next generation. We're talking very central within the respiratory system, within the lungs, that actually generates a cough reflex. So if your phlegm is in the alveoli, in the terminal bronchi, in the gas exchange areas of the lungs, unless you get it somewhere that will stimulate a cough reflex, so up to the 4th generation bronchi or above, they are not going to cough. This is the problem. This is what we need to do. We need to mobilise those secretions. So, what does happen when those cough reflexes are stimulated is you then get a deep inspiration and a closure of the glottis. As that closes, you then get a sealed vessel within your lungs, essentially. So, then you get a contraction of the chest wall and the abdominal musculature. Because you've got a closed volume, but because you've got a closed vessel, but you are reducing your volume, you are massively increasing the pressure. This is what your Valsalva manoeuvre is. You then have a rapid, active push, expiration. They are pushing out the air. And you then have the opening of the glottis, and that's your cough. That's your explosive force of air out of the lungs, and hopefully taking with it phlegm, foreign objects, whatever else is in there that has stimulated the cough in the first place. So, as I said, it has to be elicited by activation of cough receptors. Those cough receptors are central, just like as with the 4th generation bronchi and less. So again, if you've got phlegm in the peripheries, it's not going to get coughed out, because they're not going to have a spontaneous cough to be stimulated to cough it out. Hence, physio can be useful. It's really easily impaired in a sick patient. Yay, like everything else. Isn't that handy? Not. So, what we can do is we can look at either an assisted or a reflex cough. Now, the reason I put assisted / reflex is, in human respiratory physio terms, an assisted cough is where the patient starts coughing themselves, and we literally provide a... Sorry, I'm moving my hands around a lot normally when I'm talking, but I'm not used to talking with a microphone. So we have so an assisted cough is the patient themselves starts coughing. Then we will place our hands on their rib cage usually quite low on the rib cage, and we will literally help with the force of that rapid expiration, that active expiration. So that is literally just putting more oomph behind their expiration to hopefully force more phlegm out. So that, in my book, is an assisted cough. Having said that, in the veterinary text, an assisted cough is an entirely different thing, which I would call a reflex cough, which is you position them in a place with the sternum preferably splinted, so in sternal usually. You then press, or in sitting if they're able to sit, because their front legs will do the equivalent. But if they're really weak, ideally you want the sternum fixed. You then add sustained gentle pressure to the third tracheal ring, and that will then give them that will stimulate a cough. That to me is a reflex cough, because you're stimulating a reflex. That's not what your veterinary texts do. So just if you're reading books, I was going to confuse you if I didn't tell you the difference, that's all. So the rib springing during the spontaneous cough, that would be my assisted cough. That's what I'm talking about with that. So this is a reflex cough. So if you saw, my hand was, bless him, now to me, that is a fabulous noise. I know I'm weird, but that's a lovely juicy cough, and that coughed and cleared. He's not going to spit out phlegm. Dogs and cats cannot spit out their phlegm. They cough and they swallow. That is fine. That is not a problem. But it does mean you get slimy poo. If you've got slimy poo and they've got pneumonia, be happy. They're clearing their chest. This is good. I told you I'm weird. I'm really sorry. Actually, I'm not sorry at all. Positioning. So, I'm talking about chest physio. This is all stuff, the reason I'm teaching you it is because it's chest physio in its official terms. It's all stuff that you can and should, and I hope will be doing. So positioning, it's incredibly important. It's especially important in the critically injured patient. So if they can't move, you have to position them for themselves. So if they've got a respiratory problem, and they are entirely recumbent, you want to be turning them on a regular basis. If they don't have a respiratory problem yet, but you're worried they might do, then 4-hourly turns is absolutely fine. If they already have a respiratory problem and you're not going to exhaust them overly by doing so, I would go up to as frequently as 2-hourly turns. When I'm saying turns, I do not mean you leave their front end in sternal and you wiggle their legs from side to side at the back. That is not turning for respiratory. It can have its place, don't get me wrong, but it's not respiratory prevention. I'm talking about lateral, into supported sternal or sternal if they can maintain it themselves, other lateral. That's your respiratory. You need to do this. You need to have lateral recumbency in these dogs that have got respiratory complications, because you may well have problems on one lung and not the other lung. If that's the case, you want the good lung up at one point in time, you want the bad lung up at one point in time. You do them for different reasons, whether that's partly that's VQ matching, partly that's drainage of the phlegm. Do you remember what I said? Phlegm doesn't cause the cough reflex until it gets central. The best way or one of the best ways in a recumbent patient who can't move themselves, gravity. So, I've already talked about VQ match, so we need to be doing the turns to get the best ventilation perfusion matching. Give them the opportunity to get as much oxygen into their bloodstream as is possible. And the reason that we're moving them around is if you've got areas that have got phlegm in there, they're not getting oxygen in that bit of blood that's around those alveoli because they're solid. So we want we need to get the air into the areas where the alveoli are working and there's circulation. You move them around to change that. You also want to decrease the risk of pressure sores and other musculoskeletal complications. I'm a physio, I'm always going to be obsessed with bones and muscles at some point in time. And it's a major component in postural drainage. So, our absolutely fantastic head of maintenance has made me a wedge within about the first 2-3 weeks. I've been here since the beginning. They can't get rid of me. Within about the first 2-3 weeks of the hospital opening, I had to go and find him and was like, Dave, can I have a wooden wedge? And he's like, what? We now have 2 or 3 different sizes to fit different cages and different size animals. If you can get your patient in a head up tip, you will be doing them the world of good for a number of reasons. A head up tip is going to give them better VQ matching. It's going to reduce the risk of silent aspiration because you don't want them flat. So they may have, if they're truly recumbent, you may end up with them regurging without you realising, and then they're inhaling. If you've got them in a head up tip, you reduce that chance slightly. And yeah, it's better in general. Postural drainage. So, postural drainage is the use of gravity to aid secretion removal. It also increases the functional residual capacity. This is a good thing. So, functional residual capacity is just one of the lung volumes within the lungs. You want that functional residual capacity to be above your alveolar closing volume. Your functional residual capacity is basically the air left in your lungs after you've taken a full breath out. If your alveolar closing volume is above that, then it means every time you breathe out, your alveoli collapse. And then you have to breathe back in and you have to use extra force to open those alveoli up and actually be able to get the air back into them. And this is how you start to get things like atelectasis and dependent atelectasis. So better postural drainage and better positioning helps improve functional capacity. Guess what else improves functional capacity? Head up when they're positioned. Hooray! So it's indicated in patients with pulmonary contusions, atelectasis, retained secretions, altered consciousness and decreased mobility. It is not as effective as exercise. This is the first time you will hear me say that today. It will not be the last time you hear me say that today. Exercise, of all of these things, is the most effective thing you can do, but we'll talk about that later. You do need to be careful with the head injured and cardiovascular patient in certain positions within postural drainage. I'm going to show you the positions in a second. Because they can be more unstable, and some of the positions are head down positions, which you're all going to look at and go, oh my god, that's scary, because they are. And head down positions are also contraindicated with patients with megaesophagus. The point of postural drainage is that you are using posture to drain very specific segments of the lung. So in order to use postural drainage effectively, you need to know where the phlegm is, or at least have a small idea. So you can do that maybe via chest radiograph or POCUS, auscultation. Absolutely, if you're auscultating lung fields, you can find out or have a theory as to where we think the phlegm is, and then you need to position accordingly. So, as you can see there, I'm not going through all of those, you can see them, but basically they're the different positions. This has been worked out by some very clever vets a long time ago. But the black in each one of those, you've got the picture of the dog and you've got the lung above. The little black bit of lung is the section that you are draining for those. So, let's just have a think. Most common pneumonia, pulmonary complication within a dog, aspiration pneumonia. Most common distribution of an aspiration pneumonia, cranioventral. So, if you are wanting to do the cranioventral portions of a dog, they need to have their head down and they need to be, hang on, which one is it? It's that one, isn't it? It is F, where you were. Anyone ever fancied putting a dog in that position? Because I don't very often, I have to say. Unfortunately, most of the time, if they've aspirated, they've probably got a megalar esophagus, and you can't do that anyway. But my point is, and I will talk, just remember this, because I will come on to this in a second. My point is, coupage. So, we're going to talk about it, and then I'm going to talk about why I dislike it. It has its place, don't get me wrong, but it's, yeah, anyway. So, coupage is and I've called it percussion because in the human physio world, it's percussion. It hasn't been called coupage in about 80 years. I don't know. Anyway, it's a rhythmical striking of the chest wall with a cupped hand. It's performed throughout inspiration and expiration. It can be single or double-handed. You need to be careful with double-handed percussion as it can cause breath holding. It can cause breath holding in humans. You just need to keep an eye to make sure that if you are doing it double-handed, which frequently no one does, but just in case, you need to make sure that your patient is breathing in and out. It must be used in conjunction with postural drainage, and this is where I have the problem with coupage being used, because so frequently it's not used with postural drainage. What position do you, if you've done, I'm not dissing anyone here, it's all good, but just who uses coupage? Who has used coupage? So fair few of you. What position have you had the dog in? Standing? Sternal? Sitting? Yeah? So where are you moving those secretions? Because it isn't central, where they can be coughed up. That's my problem with it. It has to be used with postural drainage or it will not work. And in fact, could potentially be detrimental. It should be performed for 3 to 4 minutes over the affected lung segment only. It should be, you can follow it with vibrations. I wouldn't recommend it for you guys. Vibrations is another technique, basically does the same sort of thing, but is more complicated to learn. And I spent a while at university being shouted at by my lecturers going, that's not quick enough. But yeah, and it may require supplementary oxygen during treatment. So I'm going to show you a video of how I would do. So this was, I have to say, one of the best patients and most patient patients I've ever had. He was fabulous. He was a wonderful little pup who had a really, really nasty, in actual fact, a really unusual and really nasty, tenacious kennel cough related pneumonia. So he was a bit different, but it's still the same thing. But that was why he had no associated megalar esophagus or any other problems, which was why we could do the head down to hip. But the reason, does anyone, so you do coupage, do you know the reason for doing coupage? How do you move the phlegm though? But yes, it is by the vibrations, but the reason why, so phlegm is like, I love this analogy, phlegm is like non-drip paint. If you've got a can of non-drip paint, you open the lid, you don't stir it, you haven't shaken it, just like it says on the label, and you carefully turn it upside down, it either stays in the can or it comes out looking like a can-shaped jelly of paint. It's solid jelly-like. You put a vibrational stir that paint and then turn it upside down, and it comes out like normal paint, like a liquid. That is phlegm. That's exactly the same. So the whole point of doing percussion and coupage and vibrations or whatever you want to call them is to cause a vibration through the chest wall to then enable that solid jelly phlegm to turn into a liquid to then drain to somewhere where it can stimulate a cough reflex to be coughed up. So that's fourth, third, second, first generation bronchi. So it has to be moved centrally. So unless you're doing your coupage in relation with knowing where the phlegm is in the first place and having them positioned in a place where you can then get that phlegm to drain centrally, it's A, pointless, and B, might actually be moving the phlegm further into the alveoli and the bits of the lung that will cause gas, that actually are responsible for gas exchange. So maybe don't do it. Especially when, guess what? Exercise is more effective. So vibrations, very quickly, it's exactly the same deal, it's exactly the same theory, it just is a different technique. So this is a shaking of the chest wall. It's performed on expiration only. You need to place both hands over the affected lung segment. You're using straight arms. You do a small amplitude, high frequency shakes, and you're going to perform for 4 to 6 breaths after percussion, maybe. Maybe used instead of percussion with care in the more unstable patient. Because it's a finer vibration, sometimes the more cardiovascularly unstable patients can cope with it better, but you have to wait. You have to sort of judge it one by one, and preferably they're the ones that are on constant monitoring, so you can see exactly what you're doing to them when you're shaking them. May require supplementary oxygen during treatment. Unfortunately, chest physio tends to desaturate you before it oxygenates you. So these are vibrations, so it's a much finer, just literally shaking that chest wall, trying to such a good dog. So that's your vibrations. I would stick to that. I would, if you've got the patient that it is appropriate to be doing these on, I would just stick to coupage personally, because that took me, I know it doesn't look difficult, but that took me so long to learn. Exercise. Guess what? It's the most effective form of physio for pulmonary complications. Hooray! This is a good thing. This means you can all do it. It increases ventilation. So it increases their tidal volume immediately. We'll go through that in a second. It improves sympathetic activity. Sympathetic activity also makes phlegm thinner. Hooray! Stuff I know about sputum is just... Anyway. It prevents associated musculoskeletal complications. 2 birds, 1 stone. Hurrah! And the mobile patient should be walked for 5 to 10 minutes every 4 hours. Non-ambulatory or weak patients supported to stand and or walk with slings and harnesses for a few minutes every 4 hours. When I say exercise, I do not mean running around like a lunatic necessarily. Exercise is one level above their current highest level of ability. If you have a fully recumbent patient, it may be as little as helping them into sternal. That might be their exercise. It might be helping the recumbent patient into a supported sit. It might be helping the dog that can only sit into a stand. This is all exercise. It doesn't have to be, here's the ball, fetch. That's not necessarily the thing, because that's not going to happen with a lot of these patients. The reason it increases, so if you think about it, if you've got a recumbent patient, a really poorly patient, and you get them up and they are able to walk, you get them up and you take them out to go and have a wee, what's the first thing they pretty much do? They cough. If they've got, obviously not if they've got nothing wrong with their lungs, but if they've got a pneumonia, that's because the second you increase their physical effort, so exercise, they have to take a deeper breath. That deeper breath gets behind the secretions, which as they breathe out, mobilises the secretions. Where does it mobilise the secretions? It mobilises them centrally because the air's coming out of their mouths. And that means it gets to the fourth bronchi and less. That stimulates a cough reflex. That's why it's more effective than anything else you can do. Get them exercising. So in this case it was. So bless him, this little dude, when he was in with us, he was in isolation, obviously, because he had nasty bugs. He had horrible, quite productive cough. So you basically watched, with me waffling on in between, what we did to him 3 to 4 times a day. So I'd go in, we'd do if I couldn't get him to cough just by standing up and walking around, while we're sort of giving him a wee and preparing, because if you've got a patient that is mobile, before you shove them head down and start wibbling around on their chest, I would thoroughly recommend you let them have a pee and a poo, because that can be messy. So I would have a spontaneous cough to start off with, plus or minus assisted if necessary. Then we would take him in, get him on the wedge. Because he had a diffuse pneumonia, because of the type it was, we would do percussions and vibs on one side. We would get him up, we would turn him over, head down again, percussions and vibs on the other side. Then we would get him out and we would run him up and down here. And then at some point in time, I guarantee you, he would stop and cough the heck out of himself. And he felt a lot better for it afterwards. So, there are some reasons why you can't do all of this. So, the obvious one, flail chest and rib fractures. You can still do exercise as long as they're adequately analgesed and it's appropriate. You are not going to start bashing their chest if they have broken ribs. Undrained pneumothorax, platelet count that's too low, we're not going to hit them. This is basically all the precautions and all the contraindications anyway for your manual techniques, your hands-on techniques, so your vibrations and your coupage. It's not going to stop you from postural drainage, because that's still useful. And guess what? Exercise. You're not going to do it over areas with open wounds. You're going to be cautious and or not do it at all around subcutaneous emphysema. Pain. There is no point in doing any of this, including exercise, if your patient is in pain. Pain makes you inherently not want to breathe deeply and hold your breath to an extent. If they are in pain, they are not going to take a deep breath. They are not going to clear their cough and clear and do everything that I've just said we want them to do. Unstable cardiovascular condition, high intracranial pressures, because coughing increases your intracranial pressures, as does head down tip, as does everything else I'm doing to these patients potentially, and megaesophagus. That's my little man, Kev. He'd had a long day. Are there any questions? Do we often nebulise our patients? Unequivocally, yes. I didn't talk about it in this because it's not officially a physio technique. However, absolutely. You only ever nebulise with saline or hypertonic saline. Never, ever, ever, ever use water. It's irritant to the lungs and will actually make things worse rather than better. If you are just nebulizing for humidification, then I would suggest you just use normal saline. If you are trying to actually break up phlegm, then you need to be using hypertonic saline. It's a mucolytic and it will help to liquefy them. The other thing to also do is make sure they're adequately have enough, their fluid balance is good, make sure they're well enough hydrated. If you yourself get a chest infection and you're really struggling to clear your chest, go and drink a pint of water and then try and cough again. I guarantee you, within half an hour, it'll be a hell of a lot easier to cough that phlegm up. And I will do usually about 4 hourly, I would say.